if everybody could get seated. Good morning and welcome to our AIDS Grand Round special session, co-sponsored by ARI, CFAR, CAPS, and maybe a few comments just about World AIDS Day. Those of you who don't know, World AIDS Day was established in 1988 by a San Franciscan, James Bunn. He and his colleague were working at the WHO UN AIDS, and they said, we need a day where we call out and think about what's happened in the AIDS response, look back and look forward. So we've had a couple of events already this week looking backwards, and really today is about looking forward. And as we look forward in the AIDS movement, it's really important that we are supporting young clinicians, young investigators. And in order to do that, we need mentors. And there's a saying I really like that talent is the future of, talent is the seeds for future greatness. So those of you who are putting a lot of pressure on you, that those of you talking today, we are really looking forward to hearing from you and want to thank all the people that have participated in mentorship of those individuals. We in the ARI every year have an award, which is an award to acknowledge exceptional mentors in our program. And today we are going to acknowledge Dr. John Sauceda, and Dr. Mallory Johnson will be doing that presentation. This is going to be followed by, we're always doing learning on clinical cases and AIDS Grand Rounds, an introduction of our very newest faculty member in our division, Dr. Kyle Hunter. And he will be doing some cases. So thank you all for being here who are in person. It's lovely to see you. And thank you to those who are participating online. So Mallory, over to you.
Great. Thank you, Diane. And thank you all for coming. And those of you on Zoom, I am delighted to get to introduce Dr. John Sauceda, who is this year's recipient, as Diane said, the ARI 2025 ARI Excellence Award for Outstanding Research Mentorship. A little bit about John. He completed his doctoral training in health psychology from the University of Texas, El Paso. Came to UCSF in 2013 to join the TAPS traineeship for AIDS prevention studies postdoctoral program. And since completing TAPS, he's just been a rock star. He's successfully competed for many NIH awards. He's had a KO1, is MPI of an R25, and 3 R01s, all as PI or MPI. He also contributes as a co-investigator to many other projects. I don't know, he's all over the place. His primary research focuses on at least 2 areas. One of them is understanding and addressing health disparities, HIV and otherwise impacting Latinx populations, and also social and behavioral science to help address real-world challenges in HIV cure research. He's, at last check of his CV, he had 96 peer-reviewed publications. I suspect, since I looked yesterday, there's probably more. Without a doubt, in addition to this outstanding research, he has truly excelled in mentoring and is really an emerged leader, I'll say, in mentoring approaches. As a primary mentor, he is actively supporting 4 early stage investigators, 3 of whom have been promoted to faculty, 2 of which on K Award type career development awards. He's co-director of the mentoring program through the UCSF Bay Area CFAR, a truly amazing program, and he's really had an impact there. He's MPI of the NIDA-funded R25 SHARP summer research program for undergraduates from underrepresented backgrounds. And yes, I'm still going to talk about underrepresented backgrounds and diversity. He also helped create a separate initiative within the CFAR called the CFAR URM group in HIV research to really help bring together underrepresented minority investigators in the CFAR. And with that, expanded to an inter-CFAR network, which has been really amazing. And we are figuring out how to keep that going in spite of the current climate. He also serves, I'm happy to say, as the Associate Director for the CAPS Developmental Core, and he's done a fantastic job as there. He's also the project director of a NIAID-funded training HIV training program for undergraduates and graduate students called the CFAR Scholars Program. And so he's really been involved not just with direct mentoring, but all these other programs. From service, he serves as the chair of the UCSF Academic Senate Committee on Faculty Welfare. And he also is the faculty experience lead for our division, the Division of Prevention Science. So when putting together this nomination, I reached out to a few mentees and just there was an onslaught of interest, and several submitted their own nominations, but several also joined the nomination that I submitted. And I thought I'd give a quote from one who's not here today. We're going to hear from two who are here, one by Zoom and one in person. But this I'd like to read a quote which I think exemplifies the responses that I heard. John has been an exceptional mentor, collaborator, and advocate throughout my career. His guidance has been instrumental in shaping my research, supporting my professional growth, and providing the mentorship needed to navigate both academic and personal challenges. I am grateful for his unwavering support and look forward to continuing our productive and impactful collaboration for years to come. That is just one example of several quotes of the impact that John has had and continues to have. So I am going to be giving John the certificate in a few moments, but first I think we are going to hear from Dr. Miranda Hill about John's impact on her career. So what do I have to do? Where's the one here? Okay, I didn't want to touch the wrong thing. I'm not going to touch anything because I will somehow disconnect the entire Zoom. We're coming for you, Miranda.
Okay, Miranda should be able to.
Here she is.
Hi.
Miranda, take it away.
Yes, good morning, everyone. Again, my name's Miranda, if I haven't met you before. I'm a social scientist and assistant professor in the Department of OBGYN and Reproductive Sciences at UCSF. I owe so much. I'm indebted to the wonderful stellar mentors that I've had since I've been a postdoc in 2020 to my career progress. I owe so much. And so I appreciate the opportunity from the AIDS Research Institute, CFAR, CAPS, to speak specifically about the abundance of just expertise, knowledge, and progress that I've been able to achieve under John's mentorship. So I first met him as a traineeships in AIDS prevention studies program postdoc during a very crucial time for all of us during the height of the COVID-19 pandemic in 2020. And though our research areas did not intersect much, John was a leader in the URM underrepresented minorities group in CFAR and was always there to offer any kind of support that we needed. And so that was instrumental during that time to just encouraging us to continue despite the obstacles that we had. And when he really excelled as a mentor is when he stepped into the gap for me. When my T32 ended in 2023, working with John and his HIV cure research team provided a crucial bridge of support in my early career, enabling me to grow collaborations while also resubmitting my career development award and applying for faculty positions. In that year that I worked with him, he proved himself to be flexible, generous, patient, accessible, and affirming of my expertise. And during that time, I really flourished. I accepted the faculty offer for the faculty position that I now hold. And I resubmitted and received my career development award focused on developing and testing HIV, social network-based HIV interventions to address HIV disparities among women in the U.S. South. And if that wasn't enough, because of John, I developed new and ongoing global partnerships in the area of HIV cure research ethics, applying expertise in social and behavioral science. So, John, I know I can't see you directly, but I want to speak to you and let you know that your mentorship has had a profound and lasting impact on my career in academic medicine. I thank you and congratulate you on this well-deserved recognition and look forward to celebrating with you in person at the next available opportunity. Cheers.
Thank you, Miranda. That was wonderful. I'd like to invite John up now to. This is a surprise to you? No. Okay. John, I would like to give him our. This is a placeholder till we have the official one.
Sure.
Here is a wonderful certificate acknowledging your award, and I'd like to invite you to share some reflections and comments.
Sure. Thank you, Mallory. Thank you,
whatever
Mallory.
you wish to.
Thank you all.
Thank you.
I typed out some remarks because I wanted to get my thanks in order for everybody, and I know we don't have a lot of time, so I apologize for the speed at which I will thank everybody. Thank you, Diane and the ARI. The investments you're making in mentoring really do have an impact, so thank you for that continued support. Second, goes without saying, everybody here, the culture of mentoring here is robust. And so to walk into it, standing on the shoulders of these expert mentors sort of makes the job a little bit easier. And I take inspiration from all the people and all the mentors that I've got to work with, which includes Tor Nealons, Alicia Fernandez, Kat Christopoulos, among many others. I want to thank the individuals who have had the honor of mentoring. So thank you, Natasha, Edwin, I'm sorry, not Edwin, Etta, Jorge, Ali, Matt, there's so many others, all the mentees in the programs over the years. Thank you for allowing me to mentor you. Let's see here. As Mallory noted, we have a lot of mentoring programs going on, and I love them all. And you know, mentoring programs are a little bit different. You have to think about sort of the vision and what kind of impact you want to have. How do you want to shape people? How do you want to support people to have a long-lasting career in science and medicine? And that vision can only happen because we have the best of the best administrators in Lauren, and Joe, and Brenda, the other Lauren Dangerfield, Berta Hernandez. There's so many others that I'm only an effective mentor in those programs because we have rock star administrators and staff. So thank you, Lauren and Joe, who are here. See a couple more. I want to thank my mentoring program collaborators, Karina Marquez. I don't know if Karina's here. Thank you. I value your friendship and your collaboration. Jonathan Fuchs. Jonathan gets a special shout out. Jonathan has been my biggest advocate in mentoring since I came here in 2013. He opened the door for me. Together, we run the CFAR mentoring program. Our mentor, the SHARP program is now in year 13. We survived and we're continuing on. So thank you, Jonathan. You've been incredibly kind and generous and helped me grow. So thank you. Let's see, a couple more and then I'll be done. Monica, thank you, Monica. I know how much the CFAR mentoring program means to you. And so thank you for entrusting me with the other set of keys to that program. It's a model program, as Diane was talking about Monday, San Francisco model, in terms of other people look to what we do here to inform what they're doing. And this is the same way with mentoring. And Jonathan and Monica had really set the tone for that program for many years before I came on board. So thank you, Monica, for entrusting me with that. And last but not least, Mallory. Mallory's been my primary mentor since 2013. For those of you who don't know, I'm sure most of you do know, Mallory is the model mentor. I've learned so much. My education in mentoring is because I'm a mentee of Mallory. And so I work, you know, the quote of lesser artists borrow, great artists steal. All I've done really is steal the techniques of Mallory and then try to, you know, reframe them in my own voice. But it always comes back to Mallory. And so I try to model myself as a mentor in Mallory's image. So thank you, Mallory, for this award as well. And so next, I am introducing Natasha. Is that correct? Okay. Okay. I appreciate that. So in mentoring, to me, fundamentally, it's all about the relationship and developing deep, trustful partnerships with that fuse the visions of what sort of I want to accomplish with my career and what the Minty wants to accomplish in their career. And just a rock star success case has been Dr. Natasha Ludwig-Barron, who came to UCSF after completing a PhD at University of Washington in epidemiology. Before that, Natasha had an MPH from Emory, was working in nonprofits and worked in UC San Diego for a little bit as a research coordinator, worked in the Department of Health in LA, and so has this wide breadth of experience. And did her dissertation working with people who inject drugs in East Africa, came to the TAPS Fellowship, and since then has just flourished, getting RAP awards, the Ready Ethics award at Fordham University, getting a KO1 on the first submission, and then as of Monday, getting the CHRP grant for social behavioral sciences and HIV research. And so it has been a true pleasure and honor to get to work with Natasha. So I'm excited to be sharing that she's going to be sharing some of the work that we have going on the Texas-Mexico border, which is a place near and dear to our heart. So please, Natasha.
All right, I will try my hardest to speak as fast as everyone else. There we go. So good morning, everyone. My name is Natasha Ludwig-Barron, and I'm here to share some work that we're doing along the Texas-Mexico border. And much of this is pilot work that has led to other grants, as John has mentioned. I'm not sure why it's progressing, but just to let everyone know, so I have no conflicts of interest. I do have a few disclosures. One, that my views don't represent the views of the NIH. Also, that just by mere fact of working in harm reduction, that this probably isn't going to be a bipartisan talk, but I hope I'm in good company here. And that you know, a lot of what we are discussing is topics around addiction. And so I hope that if anyone is struggling with addiction today, that after this talk, if you stay with us, that you contact your sponsors or supporting folks. So a little bit about me. So I think John did a really great job, but I was trying to figure out ways of not pulling in the LinkedIn profile and UCSF profile. I'm a Chicana from Los Angeles, California, raised in a single parent household and first gen college student. And a lot of what I do, the work and the research that I do is because of my family history of addiction. And as John mentioned, I'm a non-traditional student, and I think that's really led me to flourish and find my way into academia in a different way. And it's really an honor to be here today sharing some of this work because it is in collaboration with some of the best advocates and some of the best mentors that I've ever had. And I know I wouldn't be here without them. So thank you, John. I stand on the shoulders of many greats, and I'm so grateful for all that you've done and your life skills, your coaching, your mentoring, and really just shepherding me through to be successful. I should have put this at the very end. Sorry. And so let's get to it and talk about where we work and who we work with. And so for the last 15 years, I've been working with people who inject drugs, mainly along the US-Mexico border. And folks who inject drugs have many identities. They're also engaging in sex work and transactional sex. Some identify as men who have sex with men. Some are formerly incarcerated. And there's also a lot of comorbidities that we also study with our group. So not only HIV, we also study overdose, Hep C, and TB. Everything that we do is through a harm reduction perspective, and we work closely with harm reduction partners, mainly in Ciudad Juarez, although that's expanding now to LA and parts of El Paso. And they offer a philosophy of meeting people where they are in their addiction with no judgment, and there's no two the same out there. They're mainly known for their syringe exchange programs, but they offer so many more services, and they're often a segue to get people into treatment when they are ready to go. And first and foremost, they are the organization that is most trusted in this community. And so without them, we cannot do the work. Much of what I do is actually using an HIV risk environment framework. I'm not going to spend too much time on this because I know there's other ecological models out there that sort of cover this. But when we're working with people with substance use disorder, a lot of times we use this risk environment framework, and it encompasses 4 main domains. You can think of the physical environment as sort of like the fixed spaces around people. The social environment is more of like your peer networks and people around you. It also includes gender and power inequities and stigma. And then the economic environment is really sort of the financials and what it takes to actually live, what your healthcare costs. And then the political environment are laws and policies that sort of dictate whether or not someone has access to care. And so let me take you to where we work. And I'm sorry if this is redundant for some people, but I think presented this at the GIS conference that was a couple of weeks ago. So Ciudad Juarez, if you look at that top right picture, is the northern part of that picture. It's dense. You see a line that cuts through, that is a freeway. And then below that, just south of that, is El Paso. So they're really adjacent. The sprawling region with more than 2.5 million residents. It's fairly transient with 35,000 daily border crossings. And politically, it's a major drug trafficking route. In the last couple of years, there's been over 6,000 asylum seekers that have come through, and I'd be remiss if I didn't talk about the violence and trauma that the region has experienced. I will also just have the caveat that most of these numbers are from 2023, and we actually don't know what the updated numbers are. In the region, substance use is a longstanding issue with more than 10,000 people who inject drugs, most of which are opioids. 1 in 4 are women, and less than 10% are living with HIV. The organization that I work with, and very fortunate to work with, is Programa Compañeros. They are based in Metro Ciudad Juarez. And they are sort of the gurus on how to work with people who inject drugs. They have really built and established trust in the community, and they are close community partners. And so what I'm going to present today is findings from Proyecto Vida, which was very much exploratory in nature. It had 3 components. So we had a survey component that looked at the HIV risk environment, hepatitis C, and overdose. And then we had a women's study component, which I will not present today, that was interested in looking at the risk environment from a female perspective. And then a biometric study that really encompassed the ethics of using biometrics within cohorts that are recruiting substance using communities. So, we sat down with our community partners and had a really great conversation about what it was that they needed, what they were seeing. And so most of our research questions are actually pragmatic in nature. And so first and foremost, I think a lot of times the assumption is that the US-Mexico border is ubiquitous, that the California-Mexico border is the same as the Texas-Mexico border, and that couldn't be further than the truth just by the naked eye, right? And so we wanted to understand, what is the prevalence of Hep C? What is the prevalence of fentanyl? What kind of drug use are we looking at? The other thing is that people were tired of just being referenced as this monolithic group of people who inject drugs. And so we know that there's underlying subgroups that need additional support. And so they wanted to understand a little bit more about those subgroups. And then within this sprawling resource limited setting, they were also interested in where are people actually sharing injection equipment. I have training in geospatial analysis, and so I was able to help them with an analysis on where people are actually sharing. So just really quick, this study ran from June to September of 2023. Eligibility criteria was injected drugs in the previous 30 days, being an adult, living in Ciudad Juarez, speaking Spanish or English, willing and able to do an HIV hepatitis C rapid test and also do a fentanyl test strip, and willing and able to provide coordinates on where people injected drugs, where they engaged in sex work and transactional sex, and other factors. And so you can really think of this in sort of 3 components. There's a testing component, there's a survey, and then there's a mapping exercise that everyone went through. And so, like I said, this people were interested to know, okay, are we the same as the California-Mexico border? And so you can already start to see numbers that are a little bit different. And mainly if you look at the common drugs that are being used, heroin and meth and fentanyl are sort of like the main drugs. When we did our survey and saw a little bit of a different story, we started to think, I wonder what's going on as far as, HIV services and prevention services, hepatitis C prevention services. And so it just really got us to think about what we could be doing that is different. The next question that they had was what subgroups or underlying clusters are really struggling with HIV prevention services. And so for this, we sought out to identify underlying subgroups using machine learning techniques and then assess which clusters or which subgroups are more likely to engage in syringe sharing. And I have to say that they knew that people were sharing syringes at high levels because they knew that when you inject heroin, you're injecting more than 3 times a day, and they just didn't have the resources to give them that many needles per person, right? And so we, for this hierarchical cluster analysis, I won't go into all the methods to save time, but basically we put in 75 pre-specified risk environment variables that included demographics, drug use variables, economic factors, and service barriers. We did our hierarchical cluster analysis. The best way to think of it is like attracts like. And so basically our machine learning algorithm is circling through every person in the analysis and seeing who is most similar and then connecting them. And it does this until everyone becomes one at the very top. And I'll show you what I mean in a second. From there, we do a logistic regression to see if any clusters are more likely to engage in syringe sharing in the previous year. And then what do they look like? What does that subgroup look like? So here's the results of the hierarchical cluster analysis. It was pretty clear to us that there were about 3 subgroups. And so those are very distinct sections there. And so group 1 had 56 participants, group 2, 49, and group 3, 44. So then when we did our logistic regression and understanding who it was that was more likely to share injection equipment, it was group 1. Just to give you a little bit of a, I didn't put all of the 75 variables here, but I highlighted some that I felt like were very different for group 1. The first is that they were our youngest group with an average age of 24 years. Most of them were engaging in polysubstance use and high proportions of crack cocaine use and sedatives. A lot of them paid for syringes in the last year on their own. And 30 experienced a personal overdose. About 20% or 1 in 5 experienced jail or prison in their lifetime. Almost half were engaging in criminalized work like sex work, selling drugs, stealing. And then a high majority experienced physical and sexual violence. And so then it became a question of like, okay, well, where are people sharing injection equipment? Where is this occurring? And so we did a 2-part process. We did a mapping exercise, which shows hotspots, and then we superimposed that with an analysis, a location allocation analysis. And so again, I won't go into a lot of the details of the analysis just for time's sake, but we did ask people, did you share injection equipment in the last year? Can you give us 4 locations, up to 4 locations? And so about 70% reported sharing injection equipment. 99% of these provided coordinates for us. And in total, we had 142 coordinates. In other words, people were willing to give us multiple coordinates. And so this is a heat map of our area with places where people shared injection drug use. You can see the US-Mexico border. That hotspot that's right there in the middle, that is Metro Ciudad Juarez, and that wasn't so surprising to us. But some of these other bubbles that were to the west, and then if you look, I don't know if everyone can see to the south, those were the more surprising ones. So then it came time to do the actual analysis, the location allocation analysis. And the question is, where can we maximize our service reach to meet people where they are in the community who are actually sharing injection equipment? And so if you look here, the nodes that are superimposed, those are locations that people provided. And the location allocation analysis gave us 3 suggested locations for outreach. One was in Metro Ciudad Juarez, one was to the west, and the one that was probably most surprising to our team at Compañeros was the one to the south that's right by the airport. And so with that, I sort of getting close to time or over time. And so I won't go over everything, but a lot of this work led to my KO1. A lot of it is being used to understand how people are able to access hepatitis C treatment, how they're able to access harm reduction service, HIV testing, and methadone. And there's also going to be a phylogenetic analysis on hepatitis C, which I'll use that cluster analysis again for. The geospatial analysis I'm using within the CHRP award that I just received. And we're also doing a participatory GIS project for the first time, so stay tuned for that. Acknowledgements, thank you so much to the team and everyone that supported this work. And thank you, and congratulations, John. Well deserved.
We have time for maybe 1 or 2 really short questions. Yes, Gabe.
Thank you. Not really.
Yeah.
I was curious if share locations or share roughly what the proportion were that didn't meet eligible criteria and then maybe not specific locations, but expectations. I'm just curious if there's sharing actually due to about privacy or perhaps even radon or other.
Great.
Is it possible to summarize this question for the folks on Zoom?
Oh, sure. So the question was for the geospatial analysis and the eligibility criteria of willingness to provide coordinates. Was that sort of a barrier? How many people participated? How many people opted out? We didn't actually, it wasn't a hard and fast eligibility criteria. We said that, we were going to be asking for this, but obviously this is voluntary. And so if you don't feel comfortable providing these coordinates, you don't have to. It was more of a way to ask them or gear them up for what's about to come. Of the people who participated, 99% provided coordinates. And that would not have been possible without working with Compañeros, right? It was all about working with a community organization. That's how we got there.
And I'm told we have time for 1 more quick question.
Yeah.
I don't know if on Zoom. Okay, we don't have time for 1 more question. I checked with
Thank you so much.
Thank you.
So it is really, we are very excited to present, and this is a major announcement that Dr. Kyle Hunter, who's in the front row, will be joining us on faculty as of July 1st, 2026. So I wanted to give a little bit of background on Dr. Kyle Hunter, who will be presenting 2 cases for us. This is our CME portion too. So Dr. Hunter was someone who always was interested in HIV. He actually went to South Africa early, didn't think he was going to be a doctor, worked with the Treatment Action Group there, then went to Human Rights Watch and worked with Syria and Bangladesh conflicts, and then actually went to Kenya and was working with LGBT communities there. And realized that he wanted to do medical school, did a post-bac program, and when he was in Baltimore was actually on the streets working with people who inject drugs as on a research project, and then came to UCSF. And the minute he came to UCSF in medical school, he started working at Ward 86. He wanted to be at Ward 86. He started shadowing multiple providers. A lot of us know him. And then during residency, he was the only person who got to do a longitudinal clinical experience at Ward 86 because he had been so dedicated to our patient population. He was in the San Francisco General PC program. He found his own fellowship money. He's on an HIV fellowship right now. And after a very competitive process, Dr. Kyle Hunter has been chosen as our new faculty member and I think emerging leader in our clinic and someone who's going to be starting with us in July. So we're very excited to hear his case presentations today. Thank you, Kyle.
Let me just
get set up here. There's a little height differential here. Huh? Oh no, it's all right. It's all right, I think. Oh yeah, let's pause here for anybody who needs this. I think there's going to be a midway point too. So, but thank you, Monica, and thank you, Diane, and thank you, Natasha, for your talk. I'm very excited to be here and share some interesting cases we've seen recently, both in clinic and on the HIV ID service in the hospital. So let's just dive right in. So first case, we have a 54-year-old man with advanced HIV, a viral load greater than 1 million, a CD4 count of 25, who presented with 1 day of fever, headache, photophobia, and a severe left eye pain to pop-up clinic at Ward 86 in September of 2025. And as a reminder to those of you who are not embedded at Ward 86, particularly online, this is our low barrier drop-in service serving our patients who are unhoused. The initial symptoms, he awoke with a headache at 3 a.m. He was endorsing photophobia and deep left eye pain. He had fevers and chills, and the pop-up team sent him to the emergency department where his temp was 38.8. Other vitals were relatively unremarkable. On exam, his left eye was injected. He had no nuchal rigidity, and he had coarse bibasilar breath sounds, and he had a negative head CT. So I've obviously edited down some of the initial data, but these are his notable initial labs. This is his left eye on presentation, and you can see the injection. He got a lumbar puncture, of course, had no white count, bland lumbar puncture. His serum crag was negative. He had cultures drawn. His CSF crag was negative, and he was started on empiric meningitis treatment. Of note, we also sent JC virus, HSV, MTB, PCR, and VDRL from his CSF. Oops. Well, this was going to be our first audience question, but I'm not sure if there's a way to fix that on the fly. Okay. We will try to log in.
Maybe can you do it without it?
Hmm.
Can you do it?
Yeah, if there's a way to get that slide. That's okay. You know what? We're gonna power through, and we're gonna pretend. Yeah, I think unfortunately, is it? No.
Seems to be like stuck.
Let's see if that works.
It's not working.
Oh, here we go. Okay. Okay, you know what? We're just gonna we're gonna pretend. We'll see what happens with the next questions, but we're gonna pretend that you didn't see the bolded questions here. the purpose of this question was really actually in honor of World AIDS Day to actually go back to some of an epidemiological point, which was despite incredible declines in HIV incidence citywide over the past decade, which group in San Francisco has not experienced proportional improvements in either HIV diagnoses or HIV-related mortality? I would expect this audience to have all gotten this question correct. And actually, it doesn't even matter because the point is to show this figure here. Many of you have probably already examined these data from the 2024 San Francisco HIV epidemiology report that was released in September of this year. But I think it's particularly relevant in acknowledgement of World AIDS Day to highlight some of the ongoing disparities in our very high resource city. You can see overall that Black African-American men living with HIV have actually seen a rise in age-adjusted mortality, while other populations have remained more steady. So while we've made incredible progress, I want to present this data in the context of a case that highlights disparities in outcomes, even with our efforts to engage people in care. And this patient we're discussing is obviously at a very high risk of a poor outcome and mortality. And then I'll also highlight that overall the number of trans women was small, so those figures were not age or race adjusted. But of course, we see very high mortality rates for that population that clearly reflect deep challenges. And then this next slide, I just want to broaden our scope slightly to look at HIV incidence for both cis men and cis women in San Francisco. And you can see disparities by race with both Black African-American men and women in the green line disproportionately impacted by new diagnoses. So back to the eye. ID is consulted. The patient cannot perceive light in his left eye. Obviously, an urgent ophthalmology consult is placed. What I'm showing you here is an OCT, optical coherence tomography. Don't ask me how they do that, but think of it as a light-based cross-section of the retina on the right, which actually shows preserved central vision in this patient, but with thinning from previous CMV. And the fundus photo on the left shows the pale mottled scars of CMV retinitis. So let's get a little bit into this patient's history. He was diagnosed in 2000 while he was incarcerated. His CD4 nadir was less than 10. His viral loads over the past 5 years have ranged between 50,000 and 1.3 million, with no periods of suppression documented since 2017. He's been on at least 3 different regimens, including an efavirenz, dolutegravir, and bictegravir-based regimens prior to his current darunavir-based regimen. And then a recent genotype from June of this year during a hospitalization is shown and is notable for an M184V and an L74I. His OI history is notable for CMV retinitis, as I mentioned, and we will get into this further on the next slide. His medical history is notable for chronic hepatitis B. He is unhoused, is an active stimulant user. And this is not primarily an ART management case. So we're going to pivot to his history of CMV retinitis. So we know that before potent ART therapy, an estimated 30% of patients with AIDS experienced CMV retinitis, which was identified as the most common end organ manifestation of CMV disease. So here's a timeline that's rather complicated based on this patient's treatment history. You can see he was first diagnosed with CMV retinitis in the first half of 2024. And since then has had a lot of difficulty with adherence to both induction and maintenance therapy and multiple rounds of intravitreal foscarnet injections in addition to systemic therapy. And I do want to highlight that the recommendation to supplement systemic therapy with intravitreal injections is based both on the experience of ophthalmologists who saw a lot of this disease earlier in the HIV epidemic and the pharmacokinetic considerations from the increased drug delivery at the site of infection. But the clinical benefit of this supplementation hasn't been confirmed in clinical trials. So there haven't been any clinical trials in the last 15 to 20 years comparing the efficacy of different regimens. I have referenced several papers here which affirm the vision-preserving benefit of therapy, but there have been no head-to-head trials comparing, for example, injections versus no injections. And then the other thing I'll highlight from this timeline is that he was off ART per our team's medical advice in consultation with ophthalmology from late July 2025 to September 2025 with sort of stuttering attempts, is what I would call it, at induction therapy until we saw him again in the hospital at the end of September 2025. And great, we do have, so this brings us to our next audience question for this case, which is in a patient with uncontrolled HIV and CMV retinitis, what is the most evidence-based approach to timing of antiretroviral therapy initiation? And while I give you a moment to think about your answer, I'll direct you to look at this picture, which shows untreated CMV retinitis with the lesions showing a sort of what is called a brush fire appearance of the retina. And let's see if this, oh, okay. Well, you know what? We're just not going to have that happen today. So I was going to say, you know, we have a nice spread, or like everyone, you know, everyone in this room knows what to do. I have that written, but that's not the case, but the answer is here. So this builds on, the answer is initiate ART within 1 to 2 weeks after starting anti-CMV therapy. This builds on prior data, or rather sort of like the lack thereof I was referencing regarding optimal treatment regimens. So that unlike down here, I have the COAT trial reference, which demonstrated a survival benefit for ART delay in cryptococcal meningitis. We actually don't have similar trial data for CMV retinitis with regards to the incidence of IRU, immune recovery uveitis, which is the eye equivalent of iris, or even vision preservation. So the guidelines are really based on expert experience, particularly during the 90s, to weigh the risk of IRU versus rapidly working on immune recovery. So in this case, he had been recommended to hold ART for 2 weeks after reinduction for treatment of CMV retinitis, but his complicated engagement in care and intermittent presentations at the hospital were very difficult to navigate from an ART restart perspective. And obviously he showed up to us at the end of September with a viral load over 1 million and had been off ART. So 10-1, he gets another intravitreal phosphocarnate injection. The fluid is sent for culture. He is continued on Valsite, induction Valsite, and continued on Simtuza, and then had been treated for CAP during this hospitalization as well. On October 7th, he was discharged after stabilization to medical respite. Medical respite is expecting him that afternoon, and very unfortunately, the patient did not show up. The twist, there's always a twist, is that the cultures from his 10-1 left eye fluid returned positive for Cryptococcus. All other cultures and studies remain negative, including his serum CRAG. He is urgently contacted. Again, the pop-up team is able to reach him and direct him to the emergency department for treatment of presumed isolated ocular Cryptococcus. So this is a very rare diagnosis. It's to have isolated cryptococcal endophthalmitis. We know that ocular involvement in cryptococcal CNS disease is often seen in the form of cerebral nerve palsies. But isolated cryptococcal ocular infection without concurrent CNS infection is rare. I will highlight this case report from Clinical Infectious Disease down on the bottom that found from 1992 that found 23 cases reported over a 27-year period prior to that. This case was from 2018 in the Journal of Indian Journal of Ophthalmology of an isolated case of cryptococcal endophthalmitis in a patient with HIV, but it's a very rare diagnosis. And so our treatment guidelines are really sort of, again, expert consensus based. I'm going to sort of glance over the ophthalmologic management part, but they basically did surgery, injected a bunch of medicine into his eye, got repeat cultures with the hopes of trying to recover some vision. His 1010 vitreous fluid cultures verify positivity for Cryptococcus in the eye, and then he did get a repeat lumbar puncture, which is culture negative to date and CRAG negative. The decision, I think the question we faced in this case was whether this was seeding from an occult CNS infection, and the ocular manifestation was just the first sign of that, which in the literature can happen, but I think the repeat lumbar puncture certainly exonerated that hypothesis. And the data we have to treat this as disseminated cryptococcus, as you see here, which is what we did, is not based on trial data, but rather on expert opinion. And then the decision was made to continue regular ophthalmologic exams to monitor the course of his disease. I think ophthalmology would have liked to continue with repeat injections, but the patient really has a hard time with those and declined further injections. Unfortunately, I don't have a neat ending to give you. This patient's vision, he was readmitted to the hospital, mostly to actually try and optimize his the management of this. The pop-up team has been working closely with him on getting him permanent housing. Last checked, and I checked yesterday in his chart, he still has no light perception in his left eye. And he's having a very difficult time following up with ophthalmology. So I think I and everybody are very worried about what's going to happen with this patient. So learning points for case one, isolated cryptococcal endophthalmitis is a rare ocular complication in advanced HIV and is managed like we manage severe CNS cryptococcosis. ART should likely not be delayed longer than 1 to 2 weeks in consultation with ophthalmology. CMV retinitis is the most common end organ manifestation of CMV disease in people living with HIV. And then again, persistent racial disparities persist in San Francisco, both in mortality and incidence. So clipping right along. Case two, very different. We have a 27-year-old man with HIV. His viral load is undetectable. He has a CD4 of 377. He was diagnosed in February of 2022. And he presents for ART optimization due to stigma and pill fatigue. He reports intermittent non-adherence, although his viral load is undetectable, and he's on Biktarvy. So here, I think the social and structural context are really important. He's from a conservative Christian community in South America. He moved to the southern US for religious boarding school, was expelled for being gay, and experiences a lot of stigma from his upbringing and in his home community. He wants to avoid taking pills in a shared living environment and wants long-acting therapy for privacy and consistency. So this is his baseline genotype, which is quite interesting because he has a transmitted E138A mutation. Other relevant data is that he's HPV negative. He's only ever been on Biktarvy. And he does report that he's a young, educated, engaged patient. And he does report taking his ART more consistently prior to his clinic visits because he knows he wants to get his viral load down. And he has expressed interest in, early on, he was asking about injectables, right? Cabrel was released in 2021 at Q4 week dosing and in 2022 at Q8 week dosing, as everybody in this room knows. And I think initially providers saw this transmitted E138A and were rightfully worried about that. And really were sort of like holding the course on keeping this patient on Biktarvy. And I'll also make a note that as I was sort of highlighting in the corner here, that this patient is sort of like purposefully, but maybe unknowingly exploiting the pharmacokinetics of our INSTI era, which dropped the viral load very rapidly, right? We expect a 2 log reduction in 2 weeks. And that's where this little AIDS citation is coming into play. This is our audience response question here. What would you decide to do with this patient's ART? Would you tell them to stick it out on BICTAF FTC? Would you start Q4 week Cabril and monitor closely? Would you try Cabril with an oral lead-in? Would you try Cabril and Len, or would you go rogue and try Cab alone and Len? I'm not convinced that this is going to work this time. It is not. What we decided to do in clinic, and again, I'll say good spread, we debated these options in clinic, and we decided to go with Cabril plus Len, and this is what I want to get into here, and I will go rapidly because I know we are on a time crunch, but let's look at that transmitted E138A and examine the trial data to help guide decision-making and weigh the risks. I know many of you are familiar with these data, but it's always helpful to dive in. The E138A confers low to intermediate resistance to rilpivirine, a modest fold change, and alone it doesn't abolish rilpivirine activity, but it can combine synergistically with other mutations to confer high-level resistance. And we know this from our phase 3 and 3B switch versus maintain trials of Cabril, which I'm not going to summarize for time's sake, but they are here. And this is really, if we zoom in on the data further, we can see in FLAIR the emergence of E138A and E138K mutations in the week 48 data. In ATLAS, we see again E138A and K, and then in ATLAS 2M, down on the bottom, I'm showing the 2 failures in the 152-week data, where we see E138A with Q148R and Y181C. And then the data that I'm not showing from the Atlas 2M trial is that 5 of the 11 participants with virologic failure through week 96 developed rilpivirine-associated mutations, including E138A. In combination with INSTI-RAMs. And so this is the data that really sort of, though E138A does not knock out rilpivirine alone, these are the data that made us think, you know what, the risk of monotherapy is too high, and we would like to add lenacapavir on. So this will be really quickly. The lenacapavir piece, I'm not going to get into. You all know and are probably going to love or excited by lenacapavir, but data presented at ID Week in October 2025 suggested which of the following about how clinicians are using lenacapavir for treatment. Primarily for multi-drug resistant. They're not using it because it costs a lot for treatment. This is the treatment cost, not the prep cost. Clinicians are using it to simplify treatment regimens. Clinicians aren't aware of Len, or they're using it as a regimen intensification to potentially reduce the viral reservoir. And again, that's not going to work. So the data shows us that actually clinicians are using it to simplify treatment regimens, in addition to some virologic considerations. But I think this slide is sort of interesting. It's this Dr. Munzer from Philadelphia Community Clinic, who looked at adults from the OPERA longitudinal cohort who had HIV and were ART experienced. And just as a reminder that Len received approval for treatment in HIV in heavily treatment experienced adults with MDR HIV, which is shown at the bottom here in the Capella trial. But his data suggests that, or this data suggests that many patients in this study were already virally suppressed, I think like 65% essentially. Viral suppression was not the primary driver to add on LEN. And so I think as we move forward, and I know we're collecting data at Ward 86 about this, and we have updated our guidelines, which I will show you in a moment, that factors other than just MDR, HIV, and achieving virologic suppression are factors in how clinicians are starting to use LEN. That's all I'm going to say about this for the sake of time. I'm going to highlight that our patient is very happy on Q6-month LEN and Q8-week Cabril. We have updated our long-acting treatment guidelines that are publicly available, including mutations that would exclude patients from being on Cabril. And I will just briefly show you the learning points, which is that stigma plays a significant role in ART management decisions still in 2025. The E138 learning point about mild to moderate rilpivirine resistance. Lenacapavir is increasingly being turned to as a means to simplify treatment regimens, and viral loads don't perfectly reflect adherence in the INSTI age, given the pharmacokinetics of those drugs. So thank you very much. I know we're out of time and many of you have places to go. So thank you.
We should let everyone go, but thank you so much. Congratulations to John Sauceda. Thank you very much for all his mentees' presentations. And really wanted to say thank you to Kyle for these great case presentations. Really interesting. One OI and not even OI, something happened. And then one ART management. Thank you.